Good afternoon, everyone, and welcome to Grand Rounds. My name is Tom Fowden, and I'm the chair and organizer of Grand Rounds. Uh, we have some people who come and do one Grand Round ever, and there are some people who come back because they feel like they've got something left to give. And then there's Sarah, who we have every year at Grand Rounds, and it really is a pleasure to have her come along and speak again at Grand Rounds. Um, she's given talks for the LGBT plus talks in February. She's been here to talk at HIV World AIDS Day before, and she's always a regular visitor in the audience as well as at the podium. So it's great to have her with us today. It is World AIDS Day on
the 1st of December.
The 1st of December, which is sometime next week. So this is the closest we could get in terms of Grand Rounds, and she is going to talk to us about why it's called World AIDS Day and not World HIV Day, and whether that is there an important distinction between those two things. And she tells me that she's got a little bit of Trump in there.
I do.
A little bit of Trump, which always goes down well. So if you could mute yourself unless you want to ask a question at the end, please put any questions into the chat. Feel free to leave your camera on if you wish or not. And Sarah's just sat next to me. We're going to swap chairs. And thanks very much.
Thanks, Tom. I actually didn't volunteer myself this time. Somebody put me forward for this. But here we are. Without further ado, it's World AIDS Day on Monday. And so this is an opportunity to talk about 40 years worth of HIV in the next hour. Okay, here we go. So we are going to have a look back. Sometimes people say don't look back, we're not going that way, but actually I think it's important to look back to remember why we're not going that way. So we'll have a little look back in time, have a look forward to where we're going, talk about a recent bump in the road in the direction of travel, and most importantly, I think about what we as individuals, as clinicians can do in relation to eliminating HIV. So having a look at where it started. 1981. Does anybody know who won the European Song Contest in 1981? Pop it in the chat. Anybody have any idea? I see Tom's just left the office. He might know. Tom, who won the European Song Contest in 1981?
Bucks Fizz?
Yes, Bucks Fizz with Making Your Mind Up. Well done. Anybody know what was the #1 music album in 1981? Oh, somebody is on the chat here. Will Cook UK. Okay, good. #1 music album in 1981? It was, in fact, where's my technology? Here we go. Queen, Greatest Hits. The highest grossing film of 1981 was, Tom Fowden.
1981? Empire Strikes Back.
Almost.
Oh.
The Raiders of the Lost Ark. All right. So in 1981, Ronald Reagan was the president of the United States, and that it was in 1981 when the then Prince Charles married Princess Diana. And this fine specimen was starting out on his cycling career as my best friend Jude and I were starting out on our academic year, starting out primary one. I'm the one with the fat face and the shifty eyes, as per. But also in 1981, getting to the point, the first cases of what later became described as AIDS were reported in the New England Journal of Medicine when gay and bisexual men were being found to have PCP and mucosal candidiasis as well as Kaposi's sarcoma, and this was written up in the New England Journal of Medicine. And just to remind you, PCP on the left there with some mixed infiltrates. People often getting recurrent episodes of PCP. And on the right here, we have got Kaposi's sarcoma. And just while we're talking about this picture here, which is, of course, from Philadelphia with Denzel Washington and Tom Hanks, the Dundee University Sexual Health Society are actually having a showing of Philadelphia in the Wilson Lecture Theatre on Monday at 12 o'clock. So bring your popcorn, bring your lunch, and watch the really excellent film. And really, HIV over the next 15 to 20 years, we witness the devastating human cost of the prolonged suffering affected by people with HIV, because it wasn't just a chest infection or some skin lesions. People were becoming blind with retinitis down to CMV. They were becoming deaf with cryptococcal meningitis, recurrent chest infections, whether it was PCP, pneumococcus, or the viral pneumonitis. Cancers, including and lymphoma, wasting, cachexia, and often due to all the various diarrheal illnesses that patients would get, Cryptococcus, Cryptosporidium, Isosporidium, CMV, HIV itself, and also the dementing illnesses. uh, Progressive multifocal leukoencephalopathy caused by the JC virus, as well as the neurotoxic effects of HIV itself. So over years, people were having serious illnesses and also all the treatments associated with these, really a nasty disease that would ultimately result in death. And when I see this famous picture of David Kirby on his deathbed in Ohio, I am struck that actually he had people with him. He had family who clearly loved him, when that wasn't the case for many, many people who died with HIV, who were more likely to be found alone in wards with food left at the door for them and people afraid to come near them or touch them, having been disowned by family and friends, and also experiencing the loss of their partners and peer group as well. So really a devastating disease, people disappearing, people not being afforded dignity at funerals and obituaries when these people's history was being rewritten. We will recognize many of these faces as people, important people, or famous people, or people who contributed to society, but that were a huge loss. But of course, there were many, many people lost. I follow a page on Facebook called the AIDS Memorial, and every day there are stories of ordinary people who also lived extraordinary lives that were lost. And I think it's really difficult to picture the vast burden when you translate that to the case in some countries in the world that were disproportionately affected. And this is a bit of an old map that really just shows the size of countries proportionate to their HIV burden. And when you translate what we know that we lost, let's say in the UK or in the West, it's unfathomable how great that loss was for particularly Southern and Eastern Africa. Where the crisis was so great that it had a huge economic impact, because the people that were affected were largely adults of productive age, resulting in a reduced workforce, reduced skills, reduced productivity and economic growth, not to mention the additional costs of care and treatment and the need to import what was needed at the time, and also the impact on widening health inequalities. These graphs here on the left, you can see globally the deaths from HIV down on the bottom left in the green lines. But at the top here, you've got men and women in sub-Saharan Africa and the death rates per 100K, which just dwarf what was happening in the rest of the world. And again, the lines at the top really showing people aged 15 to 69. So again, that productive part of the workforce being decimated. And the vertical line I've drawn on this graph is when effective treatment came into being, and by that time infections were peaking at almost 3.5, 4 million new infections per year, and the death rate was yet to peak when effective treatment became available. So that was really a look into the grim past of HIV, just to remember what happened and how we will not go back there. By 1996, we have Bill Clinton as the president, and we have Diana and Charles separating. The number one album in 1996?
Blur?
Nope.
Oasis?
No, I think Alanis Morissette, Jagged Little Pill.
Oh, okay.
Okay, and
Yeah.
the number one grossing film?
Oh, crikey.
Anybody?
Was it university?
Independence Day.
No.
Yeah.
No.
And we have this chap without a bike, possibly took his bike there on that particular journey. And here's Jude and I in our second year at university. And what happened in 1996 is at the International AIDS Society conference in Vancouver, it was finally reported that combination antiretroviral therapy with 3 drugs from 2 classes could reduce the death rate from HIV and maintain people with suppressed viral loads. And that was the first glimmer of hope for treating HIV. And since then, we have managed to develop, I say we, they have managed to develop targets to many points on the life cycle of HIV. You'll probably be familiar with non-nucleoside reverse transcriptase inhibitors, and to this day, most of our patients are on two of these, and we've developed a number of new classes. And in that time, we have moved from very toxic, nasty drugs to some very tolerable, easy to take drugs. More recently, we have capsid inhibitors, which we will go on to talk about, monoclonal antibodies, and maturation inhibitors in the pipeline. So lots of different classes of drugs. When in the 1990s, you might be taking 20 pills at different times over the day. Now, you might be just taking a co-formulation of up to 3 or 4 drugs actually within a single tablet, and we have a number of options there. And actually, in October 2021, since then we've been able to offer injectable therapy every 2 months, and we have a number of patients solely on injectable therapy. Rolling out antiretroviral treatment to where it's needed most in the world was obviously a big project. And George W. Bush implemented PEPFAR, the President's Emergency Plan for AIDS Relief, in 2003, which is really the largest global health fund targeted at a single disease. And it has achieved an immense amount across the world, but largely in Southern and Eastern Africa, both in terms of life saved, people on treatment, and people accessing preventive therapies, including pre-exposure prophylaxis. And PEPFAR has added to funding provided by a number of different streams. So domestic finance, accounting for almost half of the sort of local efforts in various countries. We've got the United States, the Global Fund, and other international donors. But you can see here on the right, it's still far off what is required. And that's going to become important a little bit later in the talk. And the prognosis now for people living with HIV is actually really good. It does depend a little bit on the duration and extent of their immunosuppression and the duration and extent of their untreated viremia. So prolonged viremia, prolonged immunosuppression will carry a worse prognosis. Some people will have been exposed to older drugs that were much more toxic, and as well as comorbidities. But we do think the life expectancy is improving towards normal, and there are some modelling studies that suggest that young people who are diagnosed early and started on treatment early might have a longer life expectancy than their HIV negative counterparts, although people living with HIV experience fewer good health years, particularly as relates to mental health. And this is what you might expect HIV to look like now, rather than David Kirby on his deathbed. We have Gareth Thomas, the picture of health. We've got James, somebody, the guy in the top right. He's a pilot from Scotland, and he was the first person to fly a domestic airline with HIV after much advocacy and support within Scotland, particularly from the Terence Higgins Trust. So yeah, we have people living well with HIV. We've also been developing prevention now that kind of treatment seems to be pretty good. Primary prevention. So the first thing is upscaling of HIV testing. When we diagnose people with HIV, we can get them on treatment quickly, which prevents onward transmission. But also, if they're negative and at risk, we can channel them into pre-exposure prophylaxis. So treatment as prevention, we now have a large body of good evidence that when you have an undetectable HIV viral load, you cannot transmit HIV sexually. It's not possible. And so that's what we call U equals U. But that hinges on people being diagnosed and being treated. And so just having a look at the impact of these various interventions in the UK, and you can see the dotted line at the top is new diagnoses, which have been coming down since 2004. And certainly a more maybe dramatic decline since 2015 when PrEP started to be used more mainstream and certainly prescribable within the NHS in Scotland since 2017. And we're not seeing AIDS diagnoses, so people with acquired immunodeficiency syndrome. Death looks like it's coming up, but that's all-cause mortality. And of course, our patients are getting aging and running into comorbidities and just dying with HIV and not from HIV. So although the rate of new diagnosis is coming down, we are actually adding to the pool of people living with HIV every year. And when we translate that to the global epidemic, when we see how many tools we've got to prevent HIV, I think that 630,000 people dying from HIV in 2024 alone is completely unacceptable. That's 8 times more people died from HIV in 2024 alone than have died in Gaza since the onset of the war. And I think that we should be horrified by that. So although we have come a long way, there is a lot yet to be done. So where are we going? Oh, back to some more stats. I don't think I put the top albums and things in 2024. Oh, I did. There it was. The highest grossing film. I did Inside Out 2.
Never seen the first one.
No, me neither. I didn't even I did know about it. And the number one album was Taylor Swift, The Tortured Poets Department. Tom's going somewhere on his bike again in 2024. Still on his bike. And Jude and I are heading somewhere on a train. And by 2024, we have Trump been re-elected and Princess Kate, who experienced her cancer diagnosis in 2024. So maybe a sign of bumpy things in the future. Where in 2024, where did we think we were heading? Our plan was getting to zero, and our plan was to get to zero new HIV infections, zero deaths from HIV-related illness, and zero discrimination. And the UN-AIDS had a number of strategies dating back to about 2011, but by 2016, we were quite specific about targets to achieve 90-90-90, which we met in the UK and in Tayside, and 95-95-95, which I will go on to describe. What that means is in order to get to zero, we have to make sure that we have diagnosed as many people as possible who have HIV. So the first 95 is that 95% of all people with HIV have a diagnosis. And so that hinges on testing. Of those, 95% should be on antiretroviral treatment, which hinges on linkage to care. And of those, 95% have to be virally suppressed on treatment. And that relies on good treatment options, access to treatment, monitoring, etc. And so the global progress is somewhat slow towards these targets. So when you think of 95, 95, 95, of course, that is the same as 95, 90, 86 of the 100%. If you need me to go into more maths, you can speak to me later. But basically, it means that 86% of all people living with HIV have an undetected viral load. And so within the UK, we are down in the world, I should say, that only 87% of people with HIV that know that they have the infection. So there's a 3.2 million people gap there. 77% of people with known HIV are taking antiretroviral therapy. So a 5.2 million person gap. So the gap is vast. Looking at the cascades of HIV prevention across the countries, I would highlight globally 87, 77, 73. And actually, the countries or the areas of the world that are doing best are actually Southern and Eastern Africa, which is really interesting. I would say the Americas are pretty bad, particularly the United States of America, where the healthcare system is not set up to deal very well with health inequalities. The data for Europe actually isn't very good, but I will go on to talk about the UK, Scotland, and Tayside data. England's performance against the data is actually pretty good. That being said, I have some problems with how they measure their data. So, for example, people that are linked into care, if they have been off the radar for 2 years, they just remove them from the denominator. Whereas certainly locally, we've had them for as long as 9 years. When we don't know what's happened to them, we keep them on our books. And so we're not necessarily comparing like with like. But certainly, England have a much higher prevalence of HIV, particularly in around London, and actually London performs much better than the rest of England and the UK. Scotland's performance. So 94% of all people in Scotland with HIV have a diagnosis, so we're not quite at target there. 91% of them are receiving antiretroviral treatment, so again, a Scotland-wide gap there. But once they are on treatment, we're meeting the target for suppressed viral load, and that's the most recent HPS report. And actually, in Tayside, you can see here that we're actually doing very, very well. The first datum, the first 95, we actually just use the Scotland data, which is based on modelling. It's based on anonymous seroprevalence studies. I'm sure it's quite complicated how they calculate that, but that is not a local piece of data. Our local data is that of all people with diagnosed HIV in Tayside, 96% of them are on treatment, and of them, 98% have an undetected viral load. And actually, all in all, 86% of all people with HIV sorry, more than 86. I think we're 88% of all people with HIV have an undetectable viral load on antiretroviral therapy. So I think Tayside, we are doing very, very well. Why are we doing very, very well? We have a relatively small cohort. We're going to talk about that. We have really good links with key colleagues, particularly within the harm reduction team, who we share care of people with particularly chaotic drug use. We share their care with the harm reduction team. Every month, we discuss every single patient who has a detectable viral load, going back 2, 3 months to make sure that we have a plan in place, and also that we document what their onward transmission risks are. We discuss all patients that we believe are in our area but are not accessing care. We look for other health records. Are they accessing care? Other types of care, etc. How can we re-engage them in care? And so I think that's a really good system we have in place. And we also have a culture of holistic patient-centered care, and we try to be responsive as much as possible to patient need, which drives some of the team to distraction. And you can see on the right there all the various things that we do within the service, whether it's supporting conception, whether it is managing pregnancies, whether it is managing drug interactions, which is a huge part of the workload, particularly as people age and acquire new diagnoses and treatments. Mental health also being a key issue that we deal with. Increasingly, prevention medicine in relation to cardiovascular risk and bone health. The other thing is about prevention and getting to zero is about maintaining people who don't have HIV and maintaining their HIV negative status, and largely the rollout of HIV pre-exposure prophylaxis. Was this the slide I meant to have here? Yes. So a number of studies showing the efficacy of pre-exposure prophylaxis, although the studies have been the best results have been in MSM, where in the intention to treat analysis, you get 86% reduction in HIV. Actually, per protocol, when you can demonstrate drug levels in people's blood, it's close to 100% effective. But unfortunately, in studies between where you're looking at sex between men and women, you do get some decrease in HIV acquisition. The effect in women has always been much less, which is largely explained by adherence, which is multifactorial, but largely around ongoing health inequalities, which disadvantage women, particularly in areas of the world with the highest prevalence. We rolled out PrEP in Scotland in 2017, and you can see here that we continue increasing numbers of men are accessing PrEP. So 13,000 people in Scotland have ever been prescribed PrEP, and the vast majority of them being gay and bisexual and other men who have sex with men. So again, a gap in getting PrEP to other risk groups that could benefit from it, particularly women and girls, particularly across the globe. And this demonstrates again the volume of women and girls affected by HIV across the world. And if we look at us in the UK, this tiny little small circle in blue, that's the women and girls in the UK. But when we go to Southern and Eastern Africa, particularly South Africa, the burden is immense. Large burdens also in India, Nigeria, Brazil, the USA, and 4,000 adolescent girls and young women acquire HIV every week. And again, we have the tools to stop this. And this is just amazing results that came out of a study in the last couple of years, looking at a new drug in a new class called lenacapavir. It is a capsid inhibitor. We do have a license for it in intensifying treatment for people with multi-class drug-resistant HIV. I have one patient on it at the moment. It's a twice yearly injection, so every 6 months. And the purpose studies, they've actually done, I think, 6 purpose studies in different groups of people, including people who inject drugs, etc., looking at it as pre-exposure prophylaxis. And the results were astounding that there were no HIV acquisitions in women who were given lenacapavir compared to the background incidence and compared to people on 2 different types of oral PrEP. And really, and this next slide is for Tom. Oh, not this one, the next one. It's a game changer. However, Gilead is currently charging $40,000 per year for this drug. But it really needs to be mass produced and rolled out, given that over 50% of global HIV infections are in women. This really is urgent because, Tom, as,
Oh,
as happened in 2013 in the NFC Championship game when Richard Sherman tipped the ball, denying the Niners their touchdown and field goal conversion, which would have taken them to a 24-23 lead. But not only was it a game changer for that game, the Seahawks went on to win the Super Bowl on the back of that. So really, proper game changer is lenacapavir.
it was robbed.
Mhm. So trying to set the scene as in terms of all the tools that we've got, how effective they can be, but a big challenge in terms of the burden and how we meet that. And we thought we were getting to zero, but there has been a bump in the road. On the 20th of January of this year, the White House, Trump, I guess. Although now I'm worried at all the things that are happening, I could be cancelled. Here we are. That'll be fine. I'm okay with that. But this was a statement that the US foreign aid industry and bureaucracy are not aligned with American interests and in many cases antithetical to American values, and they serve to destabilize world peace by promoting ideas in foreign countries that are directly inverse to harmonious and stable relations internal to and among countries. And they issued a pause in all US foreign development assistance. And that included the overnight halting of treatment programs, prevention programs for people living with HIV, employment for a number of people both with and without HIV in Southern and Eastern Africa. And UNAIDS issued a statement that if that was to be permanent, we would see 6.6 million new infections by 2029, 4.2 million additional AIDS deaths, and 3 million additional children orphaned by HIV in the next 4 years as a result of that removal of funding. My understanding is that what was felt to be life-saving treatment was reinstated, but prevention has taken a massive hit. And you can see here in Eastern and Southern, as well as Western Africa, the vast majority of prevention budgets are covered by PEPFAR. And these have just been removed. And not only that, the systems and the data systems required to collect data on the impact of these cuts have also been decimated. So actually finding out what's happening and the impact of that is also a huge challenge. The UNAIDS have issued their World AIDS Day report, and they have, I think, in trying to be quite positive moving forward, they have highlighted some good outcomes that African leaders have met together to define a new roadmap to 2030, that there has been a commitment through the Accra Reset to foster a new era of health sovereignty, rooted in national ownership, investment, and leadership, and lots of examples of increasing health and HIV budgets locally within country. Although they can't create money, it will have an impact. And so there are signs of resilience within the HIV response. One of these amazing developments over the last year is that through the Bill Gates Foundation, a deal has been negotiated where Gilead will allow generic companies to manufacture lenacapavir at the cost of $40 per year compared to the £20,000 per year, which is incredible but the infrastructure that is required to roll that out has taken a massive hit. And so, had this happened 2 years ago, it could have been so different. And was this PEPFAR decision about America first? Was it about diverting funds to the HIV response within the States? Well, they reduced their NIH funding. They reduced funding for HIV programs within the CDC. They've eliminated any policies, mandates, programs, and grant applications that mention anything to do with DEI. And in the case of HIV, where there are gender disparities and racial disparities, it's very difficult to write a proposal without EDI. But more, I don't know, uh, threateningly, perhaps, this was reported in the New York Times yesterday that the State Department has warned employees not to use government funds to mark World AIDS Day, to refrain from publicly promoting World AIDS Day through any communication channels. And I understand that government employed officials, including CDC staff, are permitted to attend World AIDS Day events, but are not permitted to speak at them. So it feels that there's something bigger going on in relation to how the administration feels about HIV. I think increasingly we're seeing a climate where human rights are at risk. We have seen more countries where same-sex relationships have become criminalized. We're seeing increasingly punitive laws on gender expression and the normalization of misogyny. LGBTQ rights appear to be up for debate. And we'll all be very familiar with anti-migration sentiment. We've also seen reduction in the funding of human rights programs, particularly also through the HIV response, which, of course, is a human rights-based response. Um, so it can feel scary, and I think a lot of us within HIV have felt quite worried about where things are going. Although it would appear that my job is pretty safe for a while. But I think it's important at times like this to look at what we can do ourselves as individuals, what is within our sphere of influence and our sphere of control. So that's what we're going to move on to. Our Here in Tayside, our cohort is increasing year on year, and what I didn't put in was our new diagnoses rates. We PHS don't publish our new diagnoses rates because they're in the category where you get little asterisks for being less than 5, and so we are seeing very few new diagnoses in Tayside. I think there might have been a year or two where we had none. The ones that we do see are almost all, but not exclusively, acquired outside of the UK. So why are our numbers increasing year on year? We've seen quite a swell in our numbers over the last while. We now have 405 patients, and that's because of people moving to Tayside with HIV, transferring their care from other centres, other countries to here. And the vast majority of those have diagnosed HIV and are on treatment. And what we have been seeing is recruitment into health and social care on the back of Brexit and COVID. Care workers were added to the shortage occupation list, allowing people to apply from overseas, and further active recruitment in some countries into our health and social care system. And applications peaked in 2023 at 18,300. So we've seen a lot of people come to Tayside to work in health and social care, often coming from areas of high prevalence of HIV, which is great. We need them working in our health and social care system. It won't surprise you to know that we haven't received any increase in our budget or drugs budget to manage that. But of course, if this continues at a time when treatment and prevention is not what it should be in other countries, we may be recruiting into the UK people who have increased health needs and costs and risk of onward transmission. So just doing a little bit of a calculation on the back of an envelope, if we have 400 people living with HIV in Tayside, and that represents 95% of all people living with HIV in Tayside, we should have about 21 people in Tayside with undiagnosed HIV. And it is your job, our job, to find them. Because they will eventually present with late stages of HIV. In England, 42% of all new diagnoses are late and 21% in Scotland. So one in four, really, one in five in Scotland have a late diagnosis of HIV. You're more likely to be diagnosed late if you're old, if you're heterosexual, particularly if you're white. So older white men, if you're looking for where you are underprivileged in this world, it is in relation to HIV that you're far more likely to be diagnosed late and risk a higher mortality, particularly in the first year. And furthermore, the cost of your care will be much higher if you're diagnosed late than if you're diagnosed early. And so the people that we think are less likely to have HIV are the ones most likely to come to harm. And the longer they go undiagnosed, the higher the chance are that they will transmit HIV on. Why is this here? Oh, yes, this was to remind you of the gap. And the gap is in that testing. We've got the HIV team, we've got it. We've got the next bits. We've got the last two bits of data. We can engage people in care. We can get them on treatment. We have an awesome pharmacist who could carry the whole show herself. What we need is for you to diagnose people with HIV. The UK guidelines delineate sort of four different testing criteria. The first one, universal testing in high prevalence areas, and unfortunately, Tayside don't meet that criteria. Opt-out testing in certain clinical settings. At the moment, that is places like sexual health clinics and drug dependency services. A termination of pregnancy. Those would be, it doesn't matter who you are or how you present. If you go to these settings, you should be offered an HIV test. High-risk groups should be screened regardless of how they present. And finally, what I want to highlight is the testing in the presence of clinical indicators, people that have symptoms or signs that may be explained by HIV. And that we're not talking about Kaposi's sarcoma and PCP, where it's pretty much pathognomonic. We're talking about possible indicators. And when somebody has a clinical indicator, we do not need you to do a risk assessment. We don't need you to ask them their sexual history or their drug use or anything. All you need to do is recognize this is a possible clinical indicator for HIV, and an HIV test should be undertaken. The British HIV Association's 2020 guidelines sort of divvies up indicators into various specialties, and so the left column is the specialty, the middle column is AIDS defining conditions, and that's HIV test, obviously, and on the right is clinical indicators, where HIV is expected to be much more prevalent in people presenting with, for example, seborrheic dermatitis or unexplained lymphadenopathies, any STI, unexplained fever, etc. And we've been trying to promote testing in clinical indicators for a long time now, actually. And within Scotland, we have decided to concentrate on a small number. Pneumonia, that's not recurrent pneumonia, that's any community-acquired pneumonia. Unexplained weight loss, unexplained diarrhea, and a mononucleosis-like illness, which could represent primary HIV infection, which is a really important point to diagnose people. So those are the clinical indicators that we would like to see HIV testing done in. A few myths and facts. So for those that are long in the tooth, although I think it's been a very long time ago when patients needed specific counselling around having an HIV test. That is not a thing anymore. It's not a thing. There's no specific counselling or discussion or anything. All right. You offer a test like you would offer any test. You also shouldn't have a high accuracy with testing, all right? If you diagnose HIV every time you test for it, you're not doing enough, all right? You should be getting many negative results, and that's all right. This isn't about diagnostic prowess. This is really about casting the net wide and picking up those few that are out there. I think there's a myth that patients don't want HIV testing, that they'll feel uncomfortable about it. And I think sometimes we project our own feelings onto patients. It really just is a test of wellness. It's a test to people probably don't want a cancer test, but we'll do it anyway because it's important. HIV testing is not different to other tests, and I wouldn't treat it as different. That being said, I do think that we probably don't obtain suitable consent for many investigations that we undertake, or that patients don't necessarily understand, which is, I think, a gap. But I think that everything should be, patients should give informed consent for everything we do for them. That HIV testing saves lives. Negative results are important because it can go on to channel them into maintaining an HIV negative status. Patients expect when they come to the hospital that if they have a blood test and anything is abnormal, some little bell will ring. They don't expect that we are specifically testing for lots of different things. So I think patients do have an expectation that we'll test them for what's appropriate. And as I said, I think patients should give informed consent for all investigations. Come to a ward near you. So if we had been in person, we had like merchandise for you. We have lanyards, both the lanyard itself and these little cards that you can put on your lanyard to remind you of when to test for HIV, and also QR codes to take you to guides for HIV testing. We also have red ribbons, etc. So the second thing that you can do, so HIV testing is the first thing. The second thing is reducing HIV stigma. Um, I sometimes hear people say that, oh, stigma doesn't exist anymore, but actually, I think if you were to ask patients, it very much does. And stigma is defined as the shame or disgrace attached to something regarded as socially unacceptable, which manifests as discrimination and ostracism. And patients, whether they experience this or not, they worry about experiencing it all the time. Um, a sixth of women, 1 in 6 women, have not shared their HIV status outside of health. 1 in 5 worry about being treated differently because of their HIV, and worryingly, 13% avoided seeking healthcare because of their HIV status. So, other conditions going undiagnosed and unmanaged because they cannot bear the stigma that they may receive. And stigma has a really erosive impact, I think, on people and their mental health. It's also the way people feel about themselves, and they stigmatize themselves. They may engage in care less well because of stigma, whether perceived or real, and how they trust their clinicians and their caregivers, and certainly impacts morbidity. And remember, people don't come with just their HIV. They come with intersectionality, so other aspects that may consider them marginalized, whether it's their gender or their race, their immigration status, their criminal justice history, their sexual orientation. So there are layers of stigma that people present with. So please be mindful of that. But what can you do? What is it that you can do to make patients feel more comfortable? I think visibility, whether it is having a rainbow badge or a red ribbon or something that says to patients, I see you. All right, I have considered you. You're safe here. And so in waiting rooms, in other areas where you can be inclusive, let patients know that you have considered their needs and that you acknowledge them. I think educating our workforce, because it's not just about clinicians. Our patients worry an awful lot about reception staff, and also nursing staff or people that they may know who work within the health service. So making sure that it's not just us that understand the facts about HIV, but the workforce. Within the last few months, I've heard cases of nursing staff taking additional precautions because the patient's viral load was very high. I've heard of a patient being put in a side room because they had HIV, and this is not appropriate at all. And we are actually working with our equality and diversity champions across NHS Tayside to include HIV stigma alongside the other champion aspects to their roles. Don't talk about people's HIV unless it's relevant. They're tired of it. They're tired of talking about their HIV when they come in with a painful knee and when they come in because they're, I don't know, I don't even know, gastritis or whatever it is. If the HIV is relevant, discuss it. I marked an essay from a student a few years ago who had written about a patient who had come into the GP with something or other. And the whole essay turned into how the fact that the woman who was on treatment with an undetectable viral load still hadn't shared her status with her partner. And I just thought, imagine going when you're A, of no risk to anybody, and you go to your GP to seek help about something. Again, it comes back to not your health, but somebody else's health. So don't talk about their HIV unless it's relevant. Don't treat them differently than other patients. There's nothing that you need to do differently. You don't need to label anything differently. You don't need to take extra precautions. You don't need to double glove. You don't need to put them last on lists. All right. And patients are very sensitive to those things. Universal precautions are universal precautions for a reason. And the last thing I was going to talk about is people first language. So the People First Charter was born out of the HIV sector and looks at the way we use language and the way that language can perpetuate stigma. And it encourages us to use positive and inclusive language and encourages us to separate people from their condition. And I'm going to go on to give some examples. Examples that you'll be familiar with is talking about asthmatics and talking about epileptics and diabetics and defining people by their condition. And it's about separating that. So rather than saying an asthmatic, you might say a person with asthma, and recognizing that's a person first before they're an asthmatic. And again, we don't talk about HIV positive people or HIV infected people. We talk about somebody living with HIV. Um, other, an IV drug user, all right, is a person who injects drugs. Okay, it's not that many more syllables, actually. I've counted them out. It does not take a lot longer to say a person who injects drugs than an IV drug user. All right. Um, I find our patients often will refer to partners or whatever as being clean, and again, getting away from that, having a negative test. Non-compliance is quite a judgmental term. Again, it's people who find it challenging to adhere. Because we've made it challenging because their drugs are toxic and they have to, disrupts their life. We talk about people failing treatment when actually the person didn't fail, but maybe the treatment failed them. Hard to reach people, or maybe people that find it hard to reach us. Maybe we are hard to reach. So again, it's looking at how we blame patients a lot of the time, and trying to move away from that. Here's my own pet peeves, and I see them all the time, and you all do it, and I've probably done it too, maybe less so now. But my personal pet peeves are when we use the words admits and denies in our letters and in our documentation, because we only use it with some things. We don't say he admits to being on salbutamol. All right, you don't admit to that. You just are, right? But he admits to smoking, or he denies injecting drugs, and that denies makes me think that you don't believe him. All right, and they betray a guilt or a shame or a disbelief, which are terms I think that belong in a court of law, but not within medicine. And instead of saying he admits to smoking, you could just say he smokes. Yeah. Or he denies injecting drugs. You could try, he doesn't inject drugs, and maybe communicate that we believe our patients. He reports, he tells me he doesn't inject drugs. I don't know, but denies is suggests that we think he's lying. All right. So try to think about ways that we can use our language to be more inclusive and positive, because words have power. They bestow or remove dignity, they build or break stigma, and they divide or unite HIV response. In summary, HIV is a devastating disease, as we've looked at, with prolonged suffering, which disproportionately impacts marginalized groups. And although great strides have been made towards making it, and I put in quotation just a chronic disease because, yes, we can manage it like that, but let's not forget that it's not just a chronic disease, it's potentially catastrophic. We do have all the tools that we require to eliminate HIV, but the structures that are in place and the funding of the structures that are in place, I think we can see are precarious and fragile. We all have a part to play towards getting to zero, and certainly here within Tayside, we could do better to test for HIV and pick up those undiagnosed infections. And that stigma really is an us problem as individuals, as who we are, and not just what we do. And that's something we can continue to work on. And in terms of within HIV, but within all of our clinic settings, I think putting people first, separating people from their conditions and using positive terminology will be empowering and dignifying for patients. And Winnie Byanyima, who's the executive director of UNAIDS, has said that World AIDS Day is a moment to renew our commitment to the AIDS response, and it is within our grasp, and we must seize it. So yeah, seize the day. Let's go forward. And finally, if you did come for the pet photos, I didn't want to disappoint. Unfortunately, my cat died a couple of years ago now. And now we have this menace to society that we have guardianship of. And there's some cushions there, as cushions as promised. Happy to take photos. Happy to take questions.
Right, shall we
Yes.
shall we swap over?
Yes, do that.
And I'll see if I can stop hearing this and then get some questions. There's claps. There's questions.
Oh.
Tay, how do you know 94% of patients with HIV are diagnosed?
So we don't, I guess, is the here.
Careful along, you're off camera.
But you've got
My office is full of crap, so
all of this. You need.
come on, shuffle across.
All right. So how do we know? We don't really know. I think I maybe mentioned that it's probably some fancy modelling stuff that they do at UK HSA and Public Health Scotland using seroprevalence data, using I'm going to say mathematical modelling and projections and science. And it's the best we've got.
Science, huh?
Science.
Science, using science.
Using science and that.
Okay, good stuff. Any more questions? Hands up or questions in the chat?
Oh, that you Jaws, that'll have been the movie thing from 1981, but no.
Oh yeah.
Yeah, good try though.
So I think about some of the chat you had of I remember in the early noughties when I was in SHO having to go through the consent process of doing HIV
Mm,
tests and how only a certain number of us in the entire hospital
yes.
were allowed to do it.
Yeah.
And I remember a gastroenterologist standing up at a talk and saying, "This is ridiculous. We just need to normalize all this, and we just
Yes.
need to do the tests. We're doing a test to save lives and make difference, and we're dancing around it, and everyone being very aghast. And here we are,
And
20 odd years later."
I know one of the problems back then was that having an HIV test, regardless of the results, might, uh, for example, negatively impact your insurance,
Yeah.
your possibility of getting a mortgage, etc. So there were consequences. Furthermore, when there was nothing that you could do about it, and you were, some people preferred not to know. Um, and also some people and would rather die than have to be diagnosed with such a horrendous disease that was so stigmatized. And in fact, there's a patient that I've seen fairly regularly over the last few years who lives as if he has HIV because he believes he does, but he won't be tested. And so he lives with all of that internalized stigma. He lives with all of that shame. I suspect he doesn't have HIV because he's been living like this for a very long time now. But he can't, that the fear and the stigma was so great. And I think to an extent, we've kind of forgotten about some of that. And it is the shadow in which a lot of people and a lot of people in some risk groups continue to live under. So it has had a big impact. But yes, normalizing HIV. And I do think that patients just expect that it's done. Like they're pretty, patients will say to me, but my doctor tested me for everything, where everything is specifically FBC, UNEs, and LFTs.
Yeah, so we all have the experience of I need to do a blood test on you, the patient. So I had blood test done by a GP last week.
Mm.
There's more than two blood tests, and sometimes you need to do something different. The you talk about normalizing things and media, TV, film is important in all that.
Yeah.
And I remember in the early mid 80s on EastEnders where
Mm-hmm.
Mark
Mm-hmm.
got HIV and then
Mm-hmm.
and then AIDS,
Yeah.
and that was the first, I think, the first very
Yeah, I think
public
so.
viewing of HIV and AIDS, and it was around the time of Freddie Mercury
Yeah.
and all that in the real world. And then in the 90s, one of my favorite medical dramas is Cardiac Arrest, which I'm sure you must have watched. You not seen Cardiac Arrest?
No,
I'll lend you the
you're a
DVDs.
bit older than me, Tom,
I'm not
remember.
that much older than you. The in Cardiac Arrest, not to spoil the entirety of season two for you, but one of the anaesthetists, fictionalized anaesthetist, develops Kaposi's
Oh,
sarcoma.
really? Okay.
And he
Yeah.
goes to see he's a trainee and he goes to see one of the consultants and says, I've got this thing in my mouth, knowing full well what he's got,
Yeah.
but
Yeah.
having to get a colleague to diagnose HIV and then disclose it because he's an anaesthetist. And there is a big thing about you can't be a doctor anymore. He says, well, I'm an
Mm.
anaesthetist. I don't put my hands in
Yeah.
cavities.
Yeah.
I'm on treatment, etc.
Yeah.
If you've not seen it, you should
Yeah.
watch it. Because it's from 1994 and you see a very different viewpoint of
And I think one of the things that actually I say to the medical students, and they'll know this, whenever I have a slide that says homework on it, it's all the things they should watch. It's a sin being one, pose being another, because I think one of the most important things about managing or caring for people with HIV is understanding the social context in which they experience that infection because it is a social experience as much as it is a medical one. And I think it's important that we don't forget that. So yes, and also like I said, Philadelphia will be shown in the Wolfson on Monday. Louise, A&E departments, yes. So opt-out testing in A&E departments has been a thing in the South for a while. It has been rolled out in Scotland. There was a pilot in Grampian and I think maybe in Lothian, but it's now being rolled out in Grampian, Lothian, and Glasgow, and we'll see what the results are. Certainly from the preliminary results from Aberdeen, I don't think they picked up any new HIV. I think you'll probably pick up a fair amount of new hepatitis C and B. I think it could be a useful opportunity to diagnose people who have fallen out of care and re-engage them in care in terms of being the key to uh, closing that gap in Tayside. I'm not sure. But I do think that things like pneumonia, weight loss, etc., are low-hanging fruit, and we're probably most likely to see those in AMU. We did audit HIV testing in AMU last year. I won't go through the results, but it's safe to say there's plenty of room for improvement, and we will. I have emailed people. We're hoping to improve that in AMU. And Christine Bird there asking a nudge rather than a question, although I wonder whether she might actually be able to help me with the answer. How will staff get their hands on the very helpful clinical indicator lanyard cards that have been developed by Christine Bird's team? And this, I expect, is maybe a question, Christine, that you can answer, but maybe we'll just distribute them.
You're hoping to see the three.
I know, I'm like, or her wee face
Sorry
appearing.
to do that. I just unmuted myself. Yeah, I was just
Hi,
saying that
Christine.
we were going to do it, but with your lovely self, kind of giving a bit of guidance on how they could be used, and maybe do some awareness with teams if they so
Yes.
desired.
I know I have, yes, yes. But in fact, I already stopped Professor Dillon actually in the corridor and handed him a red ribbon. I've given one to Tom Farden, which he's not yet wearing, but I will be liberally handing these out over the next few days as well. But yes, and there's also a workforce toolkit that's actually been developed through Waverley Care that is currently embargoed until World AIDS Day. But keep an eye out for that. That will be coming our way next week for World AIDS Day.
Excellent. The clock is ticking. It's nearly 2 o'clock. I need to go back to AMU and make a difference.
Very good. Save lives.
Save lives and make a difference.
Yes, and do HIV testing.
And where appropriate, do HIV testing with a low threshold.
Yes.
Okay. So thanks very much, Sarah,
Pleasure.
for the annual Sarah Alstaff lecture. And thank you to the HIV community for getting in touch and asking for the slot. And next week, we're back to the regular Centre for Medical Education slot on scholarship. I don't have the details of what the talk is yet, but I will find out very soon, and I'll put it in an email next week, and I'm looking forward to that. These talks go up onto YouTube. If you're watching this on YouTube, please do like, comment, and subscribe. Click the wee bell so you get notifications. And if you would like to speak at Grand Rounds, I have an almost completely empty program for the spring and summer of 2026. So if you've sat there on a talk, or you know someone's got a good talk that you'd like to invite them on, whether they're an external speaker or internally, please do get in touch and I'll give you a slot. And with that, have a good weekend and I'll see you next week.